Hello, and welcome to another session of Digital Slide Review and Sign Out. I'm Dr. Lewis Hassel, and I'm coming to you from the University of Oklahoma Health Sciences Center in Oklahoma City. Our program is part of the services provided by Digital Anatomic Pathology Academy, which grows out of a joint collaboration between Digital Pathology Association and Path Presenter. You may be interested to know that membership in the Digital Pathology Association is free to residents, students, and trainees. So you can certainly take advantage of all their resources at very minimal cost. So with that brief introduction, today's case comes from kind of the border zone sometimes between GYN and GI pathology. This is a 30-year-old woman who presented with pelvic pain, and that was somewhat cyclic, as they suspected that she had endometriosis. And that eventually brought her to laparoscopic examination, at which time they found something somewhat unexpected. So here's representative portions of her biopsies. We have several fragments. First, here in the middle, we have what looks like it's probably endometriosis. We have some glandular spaces, a little bit of stroma around, some associated hemorrhagic contents, the luminal space here. Certainly this would fit in most settings with endometriosis of the peritoneal cavity or that. But then we also have this tissue that looks like this, very kind of tree-like structure, papillary branching pattern off of the peritoneum. And of course, most gynecologic surgeons are going to immediately start to think about borderline tumors, serous neoplasms, and so forth with this lesion. So let's take a look at it. We don't see much in the way of anything that looks like endometrial type stroma here, but rather we see these sort of myxoid stromal areas of papillarity surrounded by a very nice low cuboidal bland chain-like epithelium. Occasionally bunching up here in a few areas, but the nuclei and the nuclear features are very bland, no nucleoli even, no mitotic figures, no karyorrhexis, and so forth in that fragment. Now we have one other fragment that's a similar sort of tissue here we can see. So we can imagine that this lesion was identified as being, maybe 6 millimeters to a centimeter or so in size. We don't see any underlying involvement of the peritoneal surface. And again, we see this sort of branching pattern, central fibrovascular type core, and chains of very bland looking epithelial cells here. So what is the differential for a lesion like this? Obviously, coming from the GYN side of things, we're going to think about serous neoplasms, both borderline and low-grade serous carcinomas. This would be the lowest of the low grades. Certainly, it's much lighter fare than even many of the borderline lesions. Endosalpingiosis might be a consideration, although that's usually not papillary or exophytic like that. It usually contains cystic type lesions. Adenomatoid tumor certainly is a mesothelial proliferation, but again, that usually forms a tumor-like mass that's infiltrative and circumscribed with glandular structures rather than papillary structures. Well-differentiated papillary mesothelioma, so-called, as opposed to diffuse type mesothelioma, would be a consideration. This, in fact, I believe is where we land today. For comparison, though, let's look at a couple of other papillary lesions and see how they might compare. So this is obviously an intracystic papillary lesion, and it's been classified as a borderline tumor. We have a nice striking degree of secondary branching. We have the myxoid stroma, but notice we also have other features, and notice the degree of atypia here. So certainly for borderline lesions and for well-differentiated low-grade serous carcinomas, you're going to have more nuclear and cytologic atypia variability. While this is not high-grade atypia by any means, the nuclear characteristics with occasional nucleoli, more coarse, slightly thickened nuclear membranes is more pronounced than what we're seeing in that lesion that I just showed you. Let's contrast that with a diffuse type peritoneal mesothelioma. Here we see a little segment of bowel, and we see an encased lesion here, variable amounts of fibrous tissue, some degree of sort of lace-like or maybe pseudopapillary type of proliferation here. And as we look at these cells, they have an epithelioid appearance. They're kind of sheet-like, amphiphilic cytoplasm. And again, we can see that the nuclear features are fairly low grade. They're rounded, but the chromatin is more coarse. There are a few nucleoli and so forth. So there's a degree of atypia here. And as per mesothelial lesions, we see the intercellular windows between cell groupings. And we have this lace-like pattern here as well. Now, mesothelioma obviously can have a variety of patterns, including biphasic patterns with spindle cells, papillary proliferations, and so forth. But as you'll see here, the cytology is quite different, as well as the architecture being different. So what is well-differentiated papillary mesothelioma? Well, this is an uncommon lesion. It's not frequently encountered, and often when it is detected, it's incidentally discovered. In other words, it doesn't of itself usually produce disease. It's usually discovered, as in our case, with some other disease like endometriosis. And in fact, a fairly large study from the GYN side of things found that about half of patients have concomitant endometriosis. Immunohistochemically, the lesions have all had mesothelial markers and been negative for serous markers like WT1, but will be positive with calretinin, negative for PAX8 and so forth. And follow-up, at least of a fairly large series out of MD Anderson and other institutions, 20 plus patients, found one recurrence and no deaths over very lengthy follow-up periods. And even of note, the recurrence in that series was incidentally discovered when the patient had surgery for another disorder. That said, I think there's still a little bit of uncertainty and the desire to follow these patients to detect recurrence and so forth. Probably the biggest danger may be overtreatment, and that may arise out of clinical confusion with these more diffuse and aggressive type of mesotheliomas that may warrant debulking surgeries or HIPEC type therapies, intraperitoneal chemotherapy. So you need to protect your patient from something that may actually do them harm in this situation. So our final sign out today is well-differentiated, most likely benign, papillary mesothelioma of the peritoneum. I think it's this term well-differentiated that sometimes throws people off. And I think long-term we may be, as we gather more follow-up on these patients, we may want to substitute a more clearly predictive adjective to define this lesion. Well, thank you very much for joining us for this slide review session. We hope that if you like this, you'll comment below about cases you may have encountered or other things you think should be in the differential, other incidentalomas in the peritoneal cavity. And as always, we invite you to subscribe so that you'll be able to catch any future videos that we release on our channel. So until next time, thanks for joining us.